Hello, everyone. In this session, we will walk through a USMLE-style clinical advantage on cardiogenic shock and use it to understand how to differentiate cardiogenic shock from other major types of shock. By the end of this lesson, you should be able to recognize cardiogenic shock clinically, differentiate it from hypovolemic, distributive, and obstructive shock, understand the underlying physiology and management principles. So let's get started. So we have here a small case. A 68 years old man present to the emergency department with a severe shortness of breath and chest pressure for 2 hours. He has history of hypertension, diabetes mellitus, and coronary artery disease. So the vital signs, we got temperature, we got blood pressure, heart rate, respiratory rate, oxygen saturation. We have cool extremities, as a physical examination reveals that cool extremities, JVD, and lung crackles. So ECG demonstrates ST segment elevation in the anterior leads. So the question is, which of the following best explains the patient hemodynamic status? Reduced systemic vascular resistance, decreased cardiac contractility, massive fluid loss, mechanical obstruction of pulmonary blood flow. So, what clues stands out? So, what to pick and what not to pick from the clues? So, we have chest pain, we have ST elevation, myocardial infarction, we have hypotension, we have JVD, jugular vein distension, we have pulmonary crackles, we have cold extremities. This constellation should immediately take us to think about cardiogenic shock secondary to acute myocardial infarction. So the correct answer would be B, decreased cardiac contractility. So why do we choose cardiogenic shock? So basically the heart pump is low and the cardiac output is low, the tissue perfusion is low. So let's understand the physiology here. Cardiogenic shock occurs when the heart fails as a pump. Most commonly on USMLE exams, this happens after a large myocardial infarction. In this case, ischemic damage reduces left ventricular contractility. As a result, cardiac output drops because tissues are not receiving enough oxygenated blood. The body activates sympathetic compensation, which causes tachycardia, vasoconstriction, cool extremities. At the same time, the blood backs up into the lung, producing what? Producing pulmonary edema, producing what we heard, which is the crackles, and respiratory distress. And because pressure backs up into the venous system, we see the JVD, the jugular venous distension. So, this is the key USMLE mechanism. The patient is not volume depleted. The problem is pump failure. So yeah. So how to differentiate types of shock? So we have, first of all, we have hypo, the cardiogenic shock, which is we just talked about. The problem is pump failure. The skin is cold. The JVP is high. The lung, we hear crackles. We have hypovolemic shock. So compare cardiogenic shock with other major forms of shock, because this is where many students struggle. The hypovolemic shock, think hemorrhage or dehydration. The issue here is low circulating volume. Unlike cardiogenic shock, no pulmonary edema, no crackles, flat neck venous distension of JVD. So a classic clue is blood loss or severe dehydration. Second, we have distributive shock, especially septic shock. This is completely different mechanism. The problem is systemic vasodilation, and instead of failing pump, blood vessels become excessively dilated. Students should remember warm extremities early in sepsis. This contrasts the cardiogenic shock. where extremities are usually cold because of vasoconstriction. So third, we have obstructive shock. This occurs when blood flow is physically blocked. Examples include pulmonary embolism, cardiac tamponade, and tension thorax. Patient may also have hypotension and elevated JVP, which can confuse the students. However, lung crackles usually point more towards cardiogenic shock because fluid backs up into the lung. So, this is like in a summary for all types of shock in one table. So this is like a high yield bold clues. UCMI plus UCMI plus hypotension plus pulmonary edema, think cardiogenic shock. Hemodynamically, cardiac output is decreased, and pulmonary capillary wedge pressure is increased because blood backs up into the lung, and systemic vascular resistance rises as a compensation. So to summarize all of that, cardiogenic shock is fundamentally a problem of pump failure, most commonly after myocardial infarction. The major clues include hypotension, elevated JVP, pulmonary crackles, and cold extremities. And distinguishing shock types becomes much easier when you focus on the underlying physiology. And thank you.